final, we saved the best for last, no pressure, panel where we're going to talk about sort of the legacy of, I should say, the U.S., we just learned the U.S. Public Health Service syphilis study, it sounds like the more accurate way to say it, in the healthcare setting, sort of in the treatment setting, in the community setting, what has that meant for disparities in access? And we have with us Susan Cooper, who's now with Regional One Health. I'm new enough to Memphis that that's not hard for me to say, Regional One Health, which I think is a great sort of way to say it. She's going to sort of give us her perspective from not only that position, but she was also, as you'll see, the former Commissioner of Health for the state, so she has a really rich perspective. We'll hear from Dr. Kurt Tower, who works with the West Clinic and has done a lot of interesting work around breast cancer disparities in treatment and some really innovative approaches for that. And two of his children are in here, so yes, over there they are. That you can't, not that you could tell that they're related, but if you're curious, they are. They're very tall. I'm a little jealous, that's all I know.
And I'm not.
Yeah. I don't know what that means, but I will leave that one alone.
It's one of those genetic things.
And we have Dr. Morris with the Church Health Center, which really is a unique and wonderful clinic that can give us the perspective of sort of a community-based clinic that reaches out to the working poor and those who don't have access to maybe more traditional, what we think of, routes of health. We have Yvonne Madlock, who's the director of the Shelby County Health Department. So it's a great sort of public health. What are we doing at a public health level, and how is that effective? And last but not least, we've heard faith mentioned a lot. We have Reverend Dr. Little with us, who's with the Congregational Health Network, which I learned about last fall and think it's just a fabulous, it's a part of Methodist Le Bonheur healthcare system, and it's a way to tap into the faith community and work with them to make sure we're working with the community. With that, I turn it over to this wonderful panel.
I guess that means me to start. We're really honored to be here today, and especially appreciate the attention that is being given to health equity and health disparities. And I will not profess to be any type of an expert on Tuskegee or the U.S. syphilis study and how it applies today in urban settings, but I do want to bring just some comments about the challenges we see in the separation of health and health care and the way that we tend to approach how the persons who live in our community in Shelby County and others either survive and thrive or not. So for just a moment, I want to put on my Commissioner of Health hat, which has been off for a few years, and just talk about a few of the challenges with the way we view folks in our state, in our community. All of you have heard lots of times that this is all about personal responsibility. The reason people that are sick and not doing well is that they don't make good choices. Well, the fact is, people make choices, but they make choices within the environment in which they find themselves. And that has not received enough attention over the years. It's just really been, in the past probably 5 to 10 years, that this idea of social determinants of health has really come to the forefront. And I would encourage all of you to look at the documentary Unnatural Causes, because it really highlights some of the challenges we find here in Shelby County. You know, place does matter. People who live in one zip code, say 38103 versus, I don't know the zip code in Germantown. 138. Well, close enough, right? They're different because the place they find themselves are different. Their ability to make choices are different. So if you go to this idea of social determinants of health, really only about 10% of your health is attributable to health care. We all want excellent health care when we need it, but we really need to turn our focus to how do we prevent folks from becoming ill? How do we address those issues that contribute to poor health? Things like education, violence, poverty, safety, transportation, access to fresh fruits and vegetables. You know, we need to address people where they work, where they live, where they worship, and where they play. So that's one part of my public health hat. The second part of my public health hat, and I'm going to leave all of public health to Yvonne, who is definitely the expert here, is that from the legislative point of view, part of improving health is about pulling the policy levers that can make the changes that lead to better health. But when you're trying to make policy changes in a world where politics tends to rule, I always had a little note taped on my desk that says, the best policy is always trumped by the best politics. That the best evidence doesn't always win out. And so I would encourage those of you who are in positions to influence policy to understand the political environments in which we find ourselves when we're trying to make change. So I'll get rid of that health hat for just one moment, but I'll shift to from an urban safety net hospital perspective. The mission of Regional One Health, and I'm glad I didn't have to drop a quarter in the can for calling it the wrong thing this week. I'll be able to buy something new soon because I keep making that mistake. So all my quarters have ended up over here. Is that we take care of any Shelby County resident, agnostic of payer. If you're uninsured, well-insured, poor, wealthy, doesn't matter. If you're in need of those services, the doors to Regional One Health are open. Traditionally, folks think of us as a hospital. Again, excellent health care. They don't always see that we've been moving into the community. We have 4 primary care centers who serve not just Medicaid patients or TennCare patients, but also the uninsured. And these 4 primary care clinics are located in some of the high need areas of Shelby County. If you think about how you address issues, health care is always good about anticipating that patients will come to us. If you flip that around and say, how do you engage the community? We're trying to take the frame that we should take care to the community, where people are, so that we can understand the community issues that they face. One of the issues, because this was about meaningful engagement in the communities in treatment and intervention, one of the programs I'd really like to highlight that's occurring in our new primary care clinics, which also have a new name, so I'll use the Hollywood Primary Care Clinic, is our Centering Pregnancy Program. If you know about the infant mortality statistics of the state, you'll know that Shelby County has a high infant mortality rate. It's been getting better over time. But if you drill down into those numbers, what you will find is there is a discrete number of zip codes that drive those poor numbers. One of those zip codes is 38103. And so if you want to attack infant mortality, it makes sense to take care of that community and to engage the mothers in new models of care to improve birth outcomes. At the Hollywood Health Clinic, we have one of our UT colleagues, Dr. Linda Moses, who is dedicated to improving infant mortality. She's well respected in the community because she is of that community. She has brought this Centering Pregnancy Program to the women in this area, and centering is a new model of care. Now, how many of you look like some of you have had babies, or some of you have been married to women who have had babies, and we were all babies at one point in time? But the traditional obstetrical visit is you come in, you're seen by your healthcare provider, an OBGYN physician, you go through your care, one-on-one visits, and then you deliver your baby. The Centering Pregnancy Program are group visits so that we can create an atmosphere where health assessments take place in a group atmosphere. Participants are involved in self-care, so they learn health-promoting behaviors. There's a facilitated leadership style. There's small groups of 8 to 10 women who come together, who all start their pregnancy journeys together. The sessions are between 90 and 120 minutes long. So you think about the average 7-minute doctor's visit that we tend to get. That is flipped. There's attention and education that is given, but it's not called an education or a teaching session. These are group visits. We also conduct or create an atmosphere where everyone's input is valued, so we honor the contributions of the women who participate. We involve support people, so you think about social networks in areas where there's a lack of resources. So, many women want to bring their grandmothers or their mothers with them as their prenatal support. There's an opportunity for socializing and sharing and peer learning because most of the folks in this zip code face the same kinds of issues, and so they can learn from each other. And then there's an ongoing evaluation of outcomes. What we found over time, the two outcomes that are measured are those births that go to term, so the decrease in preterm births, and the increase in birth weight, because we know low birth weight is a predictor of poor outcomes. We've been very successful over time. We've moved the model now to 3 different sites. But it's just a new way of thinking of how to deliver care. But it involves the community, it involves the patient, it's nothing about you without you kind of mentality. And again, we're creating a program that leads to not just healthful births, but also healthful lives, following the babies and the mothers for the next year after life. So just an example, and the signs are up, and they know I'll talk to a fire hydrant unless it turns red, so I'll turn it over to Kurt.
Thank you. I just want to first start out by saying it's not very often that we have the opportunity to see people that have really changed the history of man and changed the history of our country like we did with those 2 gentlemen this morning. And I thank Amy and the law school because that was just really a fantastic presentation this morning. So thank you very much. That was great. What I'm talking about today is that although I do a lot of research that would involve many of the things that we heard about the Tuskegee project and the Nuremberg studies and the Helsinki Agreement, what I'm talking about today is really breast disparity and how we're going to approach that. And many of the things, it's interesting to hear how the model is changing because many of the things I'm going to say are exactly what you just heard with a different name. And the whole point of that is what we're trying to do is we're trying to change the model of care because the model of care we have right now is not working. In Memphis right now, an African-American woman with breast cancer has 2 times the chance of dying of that breast cancer than a white woman does. Why does that happen? Well, when we started looking at it, we didn't know why. Is it genetic? Are they just not getting to the doctor? Is it an access problem? Is it a cultural problem? Is it an emotional problem? Is there something that they're not getting that we're not really delivering to them? And so what we've tried to do through Ed Rafalski and his group at the Methodist and also through our great partners, the Congregational Health Network, which you'll hear about from Perry at the end, is try to figure out what some of the parameters are. So our initial steps have been for this is to look at the numbers. How do we find out what we're trying to do? So we're trying to break it down, and the first step was to make a data pool that included all these women. How do you catch all these women? One of the first things that became apparent to us at the West Clinic is once we got a West Clinic number on somebody, once we got them into the system, we could take care of them. But they're not in the system. That's the problem. They're lost. And so we looked at various statistics or various data to look at that, and we're putting together a data pool. And some of the very interesting things that come out about this is that if an African-American woman gets screened with mammography, a lot of times that screening reveals that she has a higher intensity or a higher stage breast cancer than a corresponding white woman. Well, what does that mean? That's not an access problem in the sense that they got the mammogram, it's when they came to get the mammogram. And so the problem is that a lot of these people don't have the luxury of going for their yearly visits. They don't have the luxury of going for mammograms. They've got to worry about feeding their kids, taking care of, not losing their job. And so we have to help address those kinds of things. You heard the word transportation. Transportation is a huge thing. Childcare is a huge thing. How do you address these needs? And so what we're trying to do is we're trying to use our model of taking care of some of the breast cancer disparities, and then put a different name on it. Put it lung cancer screening, and then put prostate cancer on it, and then put diabetes on it, and try to find a model that works. And the model is, you just heard, we've got to go to these people because they can't come to us. That's become increasingly apparent. We can't be in our ivory towers and not be, well, I'm not an ivory person, but we can't be in our ivory buildings, let's put it that way. And but we have to go to them. We have to be able to deliver the care in a way that they can receive it. And that's a huge challenge. Anybody know how that works? I'm not sure how it works yet. We're trying to figure it out, but we don't know exactly how it is. And there's a whole additional part of that. We've had some fascinating discussions with some of the pastors in the Congregational Health Network, and one of them said to me, it's a cultural thing. You know, it's a cultural thing. People in the African American culture may not think about their health visits first because that's not their priorities. Their priorities are just getting through life, just making sure they take care of their kids, making sure they can pay their rent, things like that. So the wonderful things that the gentleman next to me, I think, is a huge proponent of is wellness. Let's not wait till they're ill. Let's try to keep them well. And so to try to teach them how to take care of themselves from the beginning, diet, exercise, things like that that Scott preaches constantly are really some of the most important things we can do. But back to the disparity issue, because I can get on a soapbox too. But back to the disparity issue, we found that not only were the African American women getting, they were getting accessed, but once they had an abnormal mammogram, it was sometimes 10 to 20 days longer before they got treatment from it. And sometimes if they, or let me start over and sort of give you the paradigm of how it works. You get a mammogram. If that mammogram's abnormal, then you go for a diagnostic test, which is usually a biopsy, to see whether that abnormal mammogram shows any abnormality, and then you go to treatment. Well, to get the mammogram first, there was a higher incidence of positives in the African American population, and when they got their diagnostics, they were being diagnosed at a higher stage. And then the treatment was incredible. It turned out that the treatment was only about 9 or 10 days longer, but the tail on that data, there were some women that were going 3 to 6 months after they found out they had breast cancer before they saw a surgeon, before they saw a medical oncologist. They were getting lost. The system was lost to them. And so those are the kinds of things that we had to get that data first because we could find out where can we pinpoint our activity, where can we start to go to try to make some answers for that. So that's what we're trying to do with our partners. We have some great partners. We have the Methodist Healthcare System and Ed Rafalski and Perry, as I mentioned, with the Congregational Health Network. We're working with the University of Tennessee and their epidemiology department that you just heard a wonderful representative from with Dr. Juarez. And we're working with those people to try to figure out how do we answer those questions? How do we get into that community? How do we address that so that we can get there and be there for them? Is it a mobile mammography unit? Is it something as easy as that? I don't think so. Is it trying to get child care and trying to get transportation so they can get somewhere to get tested? I think that's an important part of it. But I don't have all the answers yet, but that's the kind of research we're doing. That's not the kind of research that requires an IRB because we're not talking about individuals, we're talking about groups. But when you talk about race and health, that kind of research is critical because right now our system's failing. African American women are doing worse than white women, and we don't think it's genetic. We do know that African American women sometimes have a more aggressive breast cancer than white women do, but you know what? Our chemotherapy works better on that breast cancer than it does on some of the breast cancers that white women do. So they may have a more aggressive cancer, but we might even be able to help them more, and they don't get to us, so we can't help them. So it's a huge problem about how to address that and how to get that done. And it's really been very humbling for me to even think about the scope of the problem. And so what we've tried to do is try to nibble off, it's a huge problem, but just nibble off part of that problem and try to make a model that we can export out. And that's what we're trying to do. So I'll turn it over to the guy that really kind of taught us how to do any of this and was the first man on board, Scott Morris.
Great, thank you, Kurt. So I'm Scott Morris with the Church Health Center. It shouldn't surprise anybody that unfortunately, since Memphis is the poorest major city in America, that we have health disparities. You know, that's really evident it ought to be evident, because that's how this stuff works. If we could address our economic issues, we would not have the health disparities. It's as simple as that. And the number one predictor of health outcomes is education. And no surprise that our city's got significant education issues. So I've spent the last 27 years in Memphis being a white guy, dealing primarily with the poor African-American population. That there are challenges in doing that. What I learned a long time ago is that I could give up everything I have and spend every minute of my life among poor people, and I would never fully be integrated because my education alone would mean at any given point I could be out. All I could say is I want out and I'd be out. It's not that way if you're poor. So that creates real challenges for us to be able to advance what we all want to do. And there are a lot of leftovers from the Tuskegee stuff because on an academic standpoint, we can be very egalitarian about saying we need the research. We do need the research, but how do you get it? I have watched academics over and over again working with the whole idea, Perry can speak to this probably as well as I can, saying let's go use the church and let's go use the black church to try to advance our academic aims. And they go and they do it and it fails miserably. And people say, well, that didn't work. Well, the reason it didn't work is because the operative word was use. You know, the church has its own agenda. And you've got to figure out a way to be engaged in what the church wants. And it may not be exactly what the academic point of view is. So an example of this that we're working on now, and most everybody at this table is working on, you know, we would tell you that the number one healthcare problem in Memphis that we could actually do something about, and it would both change our economic outcome and improve our health status as much as anything else, is the issues around undiagnosed and untreated hypertension in African American men. So our approach to that has historically been, you know, it's not like we're the first people to recognize this and attack it, try to attack it. But our approach to this has always been we need to figure out how to get these men to come to the doctor and take the medicine. In my opinion, we have proven these men will not go to the doctor. You know, that cannot be our only solution. So, you know, I creatively have this idea that I think we ought to be able to find trusted mentors in the community that don't look like me, but give them the pills, give them the charge to be able to put those pills into their friends' or nephews' hands and let them be the provider. You know, I am totally convinced that that would work. The only small problem with that idea is that it's illegal. And I now realize I am talking to the very people I've been looking for 2 years. I'm talking a bunch of lawyers, Yvonne.
I hear you, Scott.
And so my opinion is you change the law, right? If it's illegal, all you got to do is change the law. I mean, because which is the greater risk? You know, what we're sitting around thinking is it's illegal because if I let my African-American guy play doctor, that he's going to go do harm. Well, we're doing far greater harm by doing nothing. You know, we actually have drugs that I'm convinced that the greatest risk of this drug is that it might give the guy a cough. I mean, that's the risk of taking this drug. And yet, I cannot find the means by which to put it into the guy's hands because mostly a bunch of white folks have said it's illegal. And it daunts us all, but we have to change the law. And I'm telling you, that I need y'all to commit to that. Help us figure out how to do this because we can do it because it would save lives in the city and is totally about this issue of health disparities. You know, one of the things that I learned a long time ago is that many people that I take care of, and we're talking on April 4th, that's absolutely why I agreed to come today, are the very people who were there, March with King. And I go in and I see these folks and I will ask, how are you doing? And the answer I invariably get is that I'm fine and blessed. Fine and blessed. There are people in this room who know exactly what I mean by fine and blessed. And I go, how could you be fine and blessed? You have nothing. You got no money. You got no capital. If the only way we value life in this world is with capital, they got no capital. They oftentimes have no social capital. Their families are a total mess. But what they have is an unbelievable abundance of spiritual capital. And what we have to do, I believe, is figure out how to help them spend some of that spiritual capital, which means this is not the way we normally think about healthcare. This is about how we engage the community in a way to say, how do we do this together? It can't just be through Dr. God. We have to change the laws. The laws are not in the favor of the poor. In no way are the laws in the favor of the poor. So it's a different mindset about how we do it, and this is how I think we approach community health and how we make a difference.
Thank you, Scott. And good afternoon. I'm Yvonne Madlock. I'm Director of Shelby County Health Department, and it is a great privilege to be here with you this afternoon, and it was an incredible experience to be at the Civil Rights Museum last night. I was not able to be here this morning, but I was there last night to hear from Attorney Gray and Mr. Jones and to bear witness to the human impact of the Tuskegee study through the BBC film that was shown last night, and to hear the dialogue and the exchange. And again, as Dr. Tower said, to be in the presence of people who really have changed the history of medicine and the history of health and public health in this time is really phenomenal, and I certainly appreciate it. And like Dr. Morris, I believe this is an absolutely perfect day to be engaged in this kind of dialogue and conversation, because it really is about the true meaning of what it means to work towards achieving equity in our country, and facing the issues that we must all face in a very honest and forthright way if we really are to make progress on issues that seem to be intractable, but really aren't if we all have, I believe, a commitment to not just addressing issues at a window dressing level, but really looking at root causes. So you've heard from physicians, you've heard from researchers, you've heard from people that are engaged in treatment, and underlying what several of them have said, I was not here for the earlier panel throughout all of it, what you heard was an emphasis on really using public health values, skills, and approaches to resolving the issues that we're facing. As I think it was Susan who used the data about the impact of the real improvements in life quality, length of life that we all see, and the opportunities to achieve a healthier community. About 20% of that opportunity lies in medical care, no offense meant. But that what really is going to change and matter if we're going to improve our community really is at addressing the social determinants of, identifying and addressing the social determinants of health. And I think part of the lesson of Tuskegee, if one of them, is that probably the most critical social determinant in our country and perhaps in the world, but I can speak for our country and I will speak about Memphis, Tennessee, is the social determinant that is the combination of race and class here in these United States. And that, as much as anything, probably more than anything, and it is related to place, but that place nexus is driven, I believe, by class and race here in the United States. I approached, thinking about my comments from the standpoint of, so what really has been the impact of this Tuskegee study and the work that was done, that's one word for it, that whole episode on the health and well-being of our country, and what has been its impact on public health and on the health of the communities in which we all live. The real question then being, so what did it matter? What has gotten better? What has gotten worse as a consequence? In terms of looking at it from the standpoint of how research has changed, I heard the tail end of the panel discussion. We know that there have been changes in regulations, there have been changes in laws that mean that we have protections for human subjects and how they can be used. There's a requirement that you get informed consent. There's all kinds of requirements. That means that the quality of the research should have a different kind of an impact. And if it does, then we would see a difference in outcomes. We would not see the levels that we do see today of disparity that still exist. It is disparity in access. It's disparity in outcome. It's disparity in treatment modalities. Studies have shown, lots of studies have shown, that regardless of whether one is insured or not, African Americans too often receive a lower quality of care and a very different quality of care, and the outcomes of care are not always as positive as they are for their white counterparts. Some of this is related to the fact that there are too few African Americans involved in clinical trials, not only as the subjects and participants of clinical trials, but also as the designers of clinical trials, the implementers and the researchers themselves. And so if we are to think about, so how do we change this picture? Part of the picture changes when we have more researchers, more physicians, more practitioners who are African Americans, who have a different level of cultural sensitivity. Again, another example given earlier was the example of Dr. Linda Moses, who works in North Memphis, who is of North Memphis, who knows the women of North Memphis, who are not probably very different other than the side of town they live in than the women who live in South Memphis. But that, we hope, brings a degree of understanding, a degree of respect, a degree of cultural sensitivity, a degree of understanding that, yes, people do make choices. They make choices that may not be my choice or your choice, but they are choices that make sense in the context of their lives. And that's what we have to be always very mindful of and respectful of. And begin to think about any interventions, any solutions, any therapeutics that we're going to discuss with them and try and see if are appropriate for them. In identifying that, that's where we've got to start. That's what public health is about. It's about starting where people are. And again, Dr. Tower and Dr. Morris both spoke about the importance of engaging people and engaging communities in the work that we do. But it starts with, with engaging people at the very, very design level, finding out what bothers you, asking that question collectively of a community. What do you want to work on? Is it hypertension? Is it infant mortality? Is it breast cancer? Or is it having a safer neighborhood? Is it having a play yard or playground in your neighborhood? Is it having street lights and feeling comfortable that your kids really can go outside and play? We tell folks all day long, you should eat right and you should get more exercise. Well, that's a really very, very hard thing to do when there are no grocery stores in your neighborhood. And it's a really hard thing to do when it's not safe to allow your children to go outside and play in the front yard, get on their bikes and ride if they have bikes, or they don't have the ability to walk to school because there is no neighborhood school. So that I would suggest to you that probably one of, again, the critical factors are those social determinants, really identifying and changing the environmental factors that contribute to people's choices that they make, that make sense for them, and really talking and working with people at that level and building from the ground up as opposed to imposing, but working with them, not researching on them, but working with them to identify the topics and the issues to be worked on and the methods in which that work should be done, and what we collectively think should be the outcome there. That's really very, very important. One other point I'll make, and I could answer some questions and provide you with some information about some things we are trying to do in that area, in that I just mentioned, working with communities to identify their needs, their interests, their commitments to improving their quality of life and their health. We've been engaged in some very exciting community engagement work called MAP, creating a roadmap for health improvement, working with communities to do that, and have engaged some 2,500 Shelby County residents to do that work over the course of the last 18 months. And the issues that they said they want to work on are not the issues that your health director might have picked. But that's irrelevant. The important thing is that these are the issues that they said are important to them. One is obesity. One has to do with, they had some very interesting things to say. But one has to do with violence as a public health issue. Not typically on the list of major topics that we think of as a problem. Interestingly enough, the issue of infant mortality wasn't there. We'll keep working on it anyway, but that wasn't on that list that was arrived at, or those 6 major topics. But I would go back to where I started, and that is that I think it is incredibly important for us to, in answering the question of what's the implication, what's the vestige of Tuskegee and the Tuskegee study. It's often said that it's exemplified or exemplifies the fact that African Americans don't trust systems, don't trust the healthcare system. I think it's important for us not to just think about it from that perspective. We've got to see it from our greater historical, social context, and we've got to continue to have very, very open and honest conversations about race and class in our country and in our community, and really try and address those issues as much as we focus on those issues that are the very purely clinical and medical approaches to improving the health of our communities. I will stop. Yes, ma'am.
I'm Perry Little, Director of Education with the Congregational Health Network of Methodist Labana Healthcare, and I just want to talk a little bit about what we do as Congregational Health Network. We did a survey that actually revealed that 80% or better of individuals who are admitted into the hospital actually have attended worship at someone's congregation within the past 4 weeks. So with that in mind, then we thought it would be good to, the best way to produce better health outcomes within the community would be to partner with the many congregations that exist within the community to try and bring about better health results. So what we did is move forward with partnering with congregations and churches to get them to enter into a covenant. We call it a covenant agreement. So we kind of use the church language as opposed to a contract. It's just a covenant agreement that they enter into to say that they're going to partner with Methodist Labana Healthcare to produce better health outcomes within the community. The pastor signs the agreement, and one of the things that's stated in there is that the pastor is going to work with us to help educate the members of the congregation and to do those things that are necessary to try and bring them into a knowledge of having and improving their health. As a result of signing that covenant agreement, Methodist Labana Healthcare says to the pastor, his wife, and any children under the age of 26, that if they are ever patients at one of Methodist hospitals, they will receive a 60% discount on their medical bill. We have roughly now about 560 congregations that partner with us. And out of those 560 congregations, we engage them in an educational process. Every Thursday evening from 6 to 8 p.m., we offer educational classes. We ask the pastor to announce it in the congregation. Each pastor appoints one liaison representative from his church to be represented there at Methodist Labana Healthcare. And that individual is also responsible for getting the information back to the other members in the congregation and inviting them to attend the classes as well. On each Thursday night for 7 weeks sessions, we do 7 weeks, and then we'll take a break for 2 weeks and come back and do another 7 weeks. But each Thursday night we do those classes at Methodist University, Methodist South, Methodist North, Methodist Germantown, We do it at the hospital in Mississippi, the Olive Branch Hospital, and we're also doing classes in Arkansas. We were in Crittenden Hospital there, but we're now doing it at one of the congregations. And we've kind of found that when we do it in the congregation, in the hospital we were running about 15, 20 people attending. And when we moved out of the hospital into the congregation, now we have about 50 people attending. So the attendance has almost doubled. But the courses that we offer on those Thursday evenings basically designed to kind of educate the congregation and the members of the congregation on how to better improve their health and take care of themselves, even with conditions that they may already have. One course that we offer is disease conditions that we live with. And we try to give it a more, a better name than just chronic diseases. So, we deal with diabetes, we deal with hypertension, we deal with heart disease and other issues. We actually do sickle cell disease as a part of that. Methodist, about 2 years ago, opened up an adult comprehensive sickle cell clinic because after patients leave St. Jude, they really had nowhere to go but to the emergency room. So Methodist is kind of stepping in to have a comprehensive sickle cell clinic where the patient can actually come directly to the sickle cell clinic without going through the emergency room. But that's one of the courses that we do. And then we do the Alliance and Aftercare class, which kind of focuses on congregational members who attend the class. Will focus on members in their congregation who come into the hospital, and once they leave the hospital, making sure that they get the aftercare, the follow-up care that they need, and the treatment that they need to continue to improve their health. As Dr. Tower was mentioning earlier, that many individuals don't do the follow-up care that they need. So we try to educate so that the liaisons and others can go back into the congregation and make sure that their members receive follow-up care. We also do a course on navigating the healthcare system designed to kind of help people deal with the complexities of the healthcare system itself. And then we do a course on cancer, medicine, and miracles. This particular course is actually taught by Dr. Tower and the physicians at West Clinic. And they go over all the different areas of cancer. But one of the things that we did over the past couple of years is, as Dr. Tower was mentioning, talk about the breast screening. We had a navigator who was specifically hired to go out into the community, and we took her into congregations and to churches and found those women who had not had mammograms done, and they actually went to West Clinic, Christ Community, and other places to get the mammograms done and be treated if necessary. So that was one of the ways that, as it related to dealing with the cancer, medicine, and miracles, that we could get into the community through the congregation and help those individuals who were in need. We also do a course on healthy hearts that kind of centers around heart disease and prevention, treatment, and also living with heart disease. The doctors at Sutherland Clinic, they do that particular class for us. We do a course on faith in the face of cancer. This is one that we're doing with the Wings Foundation. And they're also a part of the Cancer, Medicine, and Miracles class that we do with West Clinic. But this particular course is designed that the liaisons and others who attend the class will kind of go back into their congregation and establish a cancer support group so that members of their congregation who have cancer will be able to now come to a cancer support group and receive the support that they need. We do a course on HIV and STDs Uncovered, and we're doing this one in conjunction with the Shelby County government. Dorcas Young and her staff actually teaches that course for us. We are currently working on a course with Dr. Tower in West Clinic on lung cancer, and we're going to roll out the course hopefully in August, and then we'll move from there to doing the same thing that we did with the breast cancer, hopefully getting into the congregation and screening those individuals who were ex-smokers and currently are smoking to see if we can detect the lung cancer in its early stages, as opposed to waiting down the road when individuals are actually sick. And as Dr. Tower stated earlier, at that state where, the treatment, is more aggressive and more necessary than if he could catch it in the early stage and maybe cure it at the early beginning stage. We have roughly about 200 or more individuals who attend our classes on Thursday evenings, and that's across the whole system, Memphis, Arkansas, and Mississippi. So I'll stop at that point. And
Thank you so much. Now, I'm awful with the timekeeping, right? But I wanted to make sure that there was time for questions. So do we have any questions from anyone?
Again, my name is Paul Clydes. I've been here for a little over a year. We have representatives of some of the major healthcare systems. The only ones missing, I guess, would be Baptist, St. Francis, Christ, and Memphis Health Center. One of the frustrating parts is that, again, we have you all here, but again, why aren't we all working together to come up with some plans in terms of how we're addressing these issues? I mean, that to me is sort of the frustrating part. I go to the West Clinic, and then I go to Baptist Cancer, and I don't see any collaboration. We have Methodist sickle cell, and we have the Region 1.
No quarters for you.
I mean, we've got to move beyond our individual, systems, and if we're going to address the population health, how are we going to begin to do that?
I'll take a crack at that because that really is a great frustration. Unfortunately, everything we talked about up here takes money to finance, and the finance comes from the medicine machine, the medical machine that we make taking care of patients. And so it's a very competitive thing about what payers pay at what hospitals and things like that, and so there's competitive advantages to that. Methodist has looked at this as a cultural thing for them, that it really is an important thing for them to bring to the community, and they're doing that. And Baptist has their own overtures. But it's hard to get the two to work together because then there's no competitive advantage. So it does seem like it's a no-win turf, but unfortunately I think it's not so far. I think that's being leveled. I think some of the federal things with regard to insurance are leveling that field. I think the discrepancy between commercial payers and what is traditionally the government pay system is going to be lowered. And so I think that's going to be an easier hurdle to overcome. Scott takes care of people who don't have any insurance at all, and that's a huge challenge. And so it really is a difficult thing because money is the driver for all of this. None of it happens unless people get paid to do it. And so you have to go where the funds are, and the funds are so far in those large hospital systems.
So if I could take a stab at that, and I don't disagree with what Dr. Tower said, I would point out for you, I mentioned the 6 priorities that the community came up with as a result of an 18-month process. And this is to demonstrate how smart people really are. One of those 6 priorities was, or one of their identified issues that we need to work on if we're going to move the needles in Shelby County on any given health issue was, we've got to improve coordination, collaboration, and communication. And that very scarcity of resources is exactly why we need to do that. There's too much to be done and too little to do it with, that we can't afford. If we're really going to improve, all boats must rise, and they rise when we begin to work together in a far more effective way. But that really is about organizations meeting and knowing one another, realizing that my population today could be your population tomorrow and vice versa, that it's very, very fluid, and that for what we do for one group has benefit across all of the groups if indeed we do things in the right way. So we are hoping that virtually all of the strategies and all of the plans that we work with the communities to develop will really be about how we cross-fertilize the work, not only across systems, but across domains, so that we've got housing and economic development in the school system, in the public health system, the medical care community, all working together on these issues. One area where we have been doing that for the last, I'd say 10, 15 years is in the area of infant mortality reduction. We've been very, very fortunate to have had a what we call an infant mortality reduction initiative core leadership team. That's far too long a name. Yes, I know that. But they've been working together for a number of years to try and identify core strategies, common approaches, the investment that was necessary to make centering pregnancy a model here in Shelby County. A model that we implemented here in Shelby County came about because that team, that multidisciplinary team, worked with the state of Tennessee during Dr. Cooper's tenure there to really work to see if we could get those resources here, we could implement it, and we could work together. Health department teaches some of those classes. You heard Mr. Little mention the fact that we're working with him on a couple of things that they're engaged in. So that there is behind the scenes the beginning of some of it. We just need to have more and more of that kind of coordination and collaboration. That very paucity of resources does make things really competitive, but we've got to kind of rise above all of that. And we've got to adjust where those dollars really go, downstream, so that we don't need quite so many at the upstream level.
And I could not agree more. I think that one of my frustrations in 30 years, though, is I've heard that same discussion for 30 years and it's not happened. So I think that what also has to happen is people have to do what they can. Scott's done the Church Health Center. We're trying to do breast disparity. So it is a diverse field, but until this happens, which frankly, unless there's big changes, it's not going to happen. We have to do the best we can, and that's what you're hearing is people are trying to attack the situation as it can, understanding full well that what you said is exactly nirvana. That's exactly what we would want, but we don't have it. And if we wait for it, more and more patients will drop through the cracks. So we do what we can.
Yeah.
We work on. I have 1,000 meetings with everybody trying to get everybody together. But in the meantime, more and more women are dying of breast cancer, and so you just have to keep going. You just do what you can.
Well, there's this concept these days about collective impact, and it's about multidisciplinary groups coming together across communities, across domains, identifying a common goal. Common metrics are going to measure. Common accountabilities are going to hold each other to. It does take time to work through those things. It doesn't mean in the meanwhile you stop doing your thing at the best level, on the highest performance level you can. But hopefully, and then you've got to disseminate what you've learned and the successes you have had. And I would say that in infant mortality, where we've seen a tremendous decrease from a community rate that was probably close to 18 to a community rate that's dropped below 10 deaths per 1,000 live births. A year ago, we're up a little bit this year, but that's what happens with infant mortality. It bounces around a lot as an indicator. But I would submit to you that some of that success is as a consequence of us really doing what we talked about doing, at least for that particular issue. It's hard, slogging kind of work, but it really is work that has benefit over time. So, but it's a good point. It is necessary.
I have a question. I'd like to know from Mr. Cooper or one of you the status of Baby Land.
What? I'm sorry?
I don't know.
Baby Land.
Baby Land is the name that is sometimes applied to the cemetery that is owned by Shelby County government, in which infants, low-income infants, are buried when their families do not have another means of assuring that their remains are laid to rest. I'm not sure what you mean by the status of it, but it is there. It's the Shelby County Cemetery, and it's the section of the cemetery that is dedicated.
I'm guessing you're probably referring, there was a documentary film called Babyland a year or so ago about this whole issue. And the issue is just babies die in Memphis and they shouldn't. And the fact is, to Yvonne's point, there is a cemetery for indigent babies, and it's just sad that it even exists. But particularly after that documentary, I assure you, the cemetery itself is well taken care of. The problem is, why does it happen in the first place?
And it is an example of the fact that those infant deaths occur disproportionately in low-income communities and for families where there has been inadequate access to lots of resources, including care.
Thank you.
I got a quick question. Would like to know your response to one, because I've gone to a couple of these type of conferences on health and race. As Ms. Madlock said, that until we deal with the issue based on health, on race and class, I think we have to take a serious look at that and the disparity on treatment. But then we got thrown out that we have enough doctors in America. The problem is that the white doctors are begging for patients while the black doctors have patients sitting in their waiting rooms that they are overworked. I'm just wondering, what's your thought about that? Treatment and disparity, here in America.
I'll take a crack at that. I'm not aware that everybody thinks there's enough doctors in America, first of all. And secondly, I'm not sure, I think that, I'm not sure that there's a lot of empty waiting rooms, so I don't know exactly what you're referring to. But there's no question that African American people feel comfortable around African American physicians. They like seeing who they are, just like white people feel that way as well. And I think that that's part of the trust situation that was talked about earlier, and one of the most important words that we can throw around in this kind of discussion is that we have to become less important. Skin color needs to become less important. How that happens, though, is something that I'm not sure is it's certainly doable, but it's a long process. One of the things I think that's very important is I think if you look at the percentage of African Americans in the medical school classes now is up considerably, and so there's going to be a lot more African American physicians when you think about the whole percentage of the physician population. I think that's a very positive thing. Same thing is true of women. There's probably more women than there are men now in medical school classes. And so I think those are the ways you try to attack that. I think it's a generational thing. I'm not sure that in our generation we're going to fix that, but I sure hope in my new grandson's generation they'll fix it.
Yeah, I really think the issue that you're addressing, though, is that if you're a doctor and you have a patient that has FedEx insurance, there are a lot of doctors who want to see that patient. But the number of doctors who take TennCare is like pathetically small. So that's whether you're black or white from the provider standpoint. The issue is really the location of those doctors' offices. So North and South Memphis, you start adding up the number of physicians there, the number is really, really small. We got plenty, I think, in Germantown and Collierville. Could be wrong, but that's the issue. And I don't really see that changing. You know, we have doctors that compete for patients, and we have patients that compete for doctors. No question about it. That disparity, I don't see how it changes without intentional decisions. Now, I will say there's this whole issue of employed physicians might change that. 60% of the doctors in Memphis right now work for one of the hospitals. You know, that's changed in the last 5 years. You know, those doctors are on salary, and they're not competing anymore. They don't care who what insurer the patient has. They get paid the same. So as long as Methodist and Baptist and St. Francis and Region 1 is willing to employ physicians and put them where there's a need, that could potentially change the whole dynamic.
Kathy, there are a lot of really great evidence-based programs out there centering pregnancy, nurse-family partnership program, lots of home visitation programs at work, and as well as increasingly interventions that we know will work for obesity, like an hour of exercise for kids after school, that kind of thing. What I'm wondering is there any forum where we can really begin to elevate the knowledge of those programs at the political level and the policy level, so we can elevate those and begin to scale them up so that we're not just serving 700 families through home visitation, but instead we're serving the 2,400 teenagers in this community who give birth and really need those services. And so how do we scale those up? You know, what kind of forum can we create?
I totally agree, it's all about scale. It is all about scale. And I think in Memphis, number one, there's almost across the board agreement about wanting to do this and make it happen. There's no competition between Methodist and Baptist over this issue. They all agree the same thing. And we have actually in Memphis created a potential means to make this happen through this entity known as Healthy Shelby under the umbrella of Memphis Tomorrow. You have the 27 largest businesses in Memphis come together along with all major healthcare systems in Memphis saying we want to work together on these issues. So we've created a governance that no other city I know has been able to pull together and say we will work together on this stuff. Now it becomes hard. Now it becomes really hard because this is still a city of 1 million people and most of y'all never even heard of Healthy Shelby and you're not invited to the meetings, and how do you do this, and how do you create communication? I mean, I don't know how you do that. This is what I do on a regular basis, and it is one of the hardest things I've ever done because, at the end of the day, I'm a doctor and a preacher, and I don't know how to do this communication stuff in today's world till you get the input you need. But if you can't take it to scale, it's really not going to make much difference.
How do you help me to help you? Somebody that's, I have health insurance, I go to the doctor regularly. When you are reaching out to those individuals that may not have insurance, that may not go for their regular, how do you help me to help them help them?
Great question.
Because if it's easier, and everybody today they like to have all these things going on, but if you make it easier for me to help you, then I'll be able to help the other people.
And I would say that from one perspective, as it relates to the Congregational Health Network, that as you come and receive the training, then you go back to your congregation or to your community, and you share that with others, and hopefully thereby you can help them, and we're helping you to help them get the health care treatment that they need.
I think that's an excellent way. We are working with, we have worked with and will continue to work with at least 2 community organizations where we're doing some, essentially, I won't call it lay health worker training, but what we're trying to do, this is again around the issue of infant mortality, is to give people information, train folks so that they can be their resident neighborhood experts or identify those folks who are those trusted informal leaders in their community, inform them and allow them to be the kind of foot soldiers for health in their communities, armed with additional information, etc. Any number of the teams that we're working on with Health in Shelby, and I'm looking at Dr. Morris in that regard, have room on them for the use of volunteers and folks who can be a part of those initiatives. One of the things we're doing with Health in Shelby is a big campaign on safe sleep. And we're using students, for example, as safe sleep ambassadors who are at health fairs. They are informed within their own spheres of influence and can provide basic information, the ABCs of sleep. Babies do better and don't die nearly as much if they sleep alone on their back and in a crib that's their own. A very simple message, but how do you operationalize that and turn that from the message of my generation is that, thank God my children all lived, that they should go to sleep on their tummies, which is not what we teach today and that kind of thing. So there are probably different ways and different approaches that could be used depending upon any individual's level of interest, what organizations they're connected with, and they don't have to be connected with any, that we could plug them into.
Yeah, but I can't possibly let this go without saying, you need to advocate for the expansion of Medicaid in Tennessee.
That too.
I mean, that would make a difference for 80,000 people in Shelby County. That one thing, and I'm sorry it comes down to one person, and my good friend, the governor, but it takes one person to decide to do this. This is not a Washington decision. It comes down to one person.
Dr. Morris, what about the idea of using legislation to increase health education in the schools? Just like I think the schools need to have more education about civics and about how the processes work. What about working along those lines to start younger and more frequently exposing children to being able to make better decisions?
If we're talking legislation, that's above my pay grade, so Susan Cooper can answer that question easily.
Right. Back to that politics statement. So they're actually, Tennessee was the first state in the nation to fully fund the coordinated school health program back in 2000 and something or another one of the lifetimes, 6, 7, 8, somewhere in there, which really does focus on multiple dimensions of school health, starting with preschoolers on up. They focused on obesity, healthful messaging. We worked with the federal government. We've got there are different certifications the schools can get. I'll give an example of the school we went to in Cookville, where in every grade they integrated health messaging, whether it was a math lesson, a social studies lesson, at the appropriate grade level. Funding for the coordinated school health program's always on the block. You know, everybody's got to make choices about where you make the investments, and that comes down to our individual responsibilities for knowing our legislators and having that personal relationship with them, because you know, a legislator gets all kinds of letters that says, you know, you need to do this, fund this. But if you start it with, my name is Susan Cooper and I happen to be a voting member of your district. Well, first of all, they'll read that one. And then it's, I happen to have an area of expertise in child health, public health, school health, whatever. And I urge you to vote yes or no on these types of things because of 3 bullet points. You need your elevator speech, you know. It's, you know, or here is how, I mean, tell a story. Here is how my child was affected, or the children of my neighbors were affected. But at the end of the day, when that, you know, the revenues don't come into the state, the governor and the legislature have to make some decisions about what programs to not fund. And I mean, it's like making sausage, and it is an ugly process. And you know, fund a fish farm somewhere or fund coordinated school health. Those are the kinds of decisions that get made at the state and in Washington. It doesn't matter where it is. But I think that collective voice around here are 1, 2, or 3 things. I mean, we tried to fund Nurse Family Partnership and all kinds of things, but it's about those relationships with your legislators to say this is important to us because of this. And sometimes you have to work at it and work at it and work at it, but I would say do the hard things first because they're going to take a long time.
The role of advocacy and being informed and informing legislators and letting them know that you are informed and have a position on something and are watching their vote helps them chop the meat a little differently and put a different spice in that sausage as they're making it. And so I do encourage that.
Yeah, the other thing is invite them to wherever it is you are. You know, start thinking about your advocacy as well. Get involved with the school boards, you know, run for office. I mean, this is your opportunity, and find where you can make a difference and start building that political career for yourself. I'm way too old right now, but, you know, but find a cause. That's it.
Any other questions? All right, thanks so much.